We'll start with neonatal jaundice. We very well know that neonatal jaundice is the most common problem seen in neonates in the initial days of life, and there are various causes of neonatal jaundice. Jaundice is the most common abnormal finding during the initial weeks of life. Over two-thirds patients develop clinical jaundice. Typically, there is a cephalopedal progression of yellowish discoloration of the skin. Means this jaundice starts from the face and then goes to the trunk and then the lower limbs and arms. Normal adult bilirubin is less than 2 milligram per deciliter. In newborn, it reaches normally up to 12 to 15 milligram per deciliter. Mechanism of jaundice, as the hemoglobin there is lysis, as we know that the in adults the lifespan of RBC is 120 days, while in newborns it is 90 days. So hemoglobin RBCs are going to lyse faster, or lysis of it is faster than the adults. So once the hemoglobin RBC lysis is there, heme and globin they are separated. Heme is converted to biliverdin by heme oxygenase enzyme. Biliverdin is converted to bilirubin by biliverdin reductase enzyme. This bilirubin is an unconjugated form of bilirubin which leaves the reticuloendothelial system and enters the plasma. In blood, it is bound to albumin. This is carried now. This albumin carries the bilirubin to the liver. In the liver, the hepatocytes are the smallest unit of the liver. They contain a Y protein or ligandin site on its cell wall membrane. So hepatocyte is a ligandin protein on the cell wall. Through this ligandin, this bilirubin enters the hepatocyte. This bilirubin first gets detached from the albumin and is bound to this Y protein. From here, it is taken up inside the cell. It goes to the endoplasmic reticulum of the hepatocyte. In the endoplasmic reticulum, conjugation takes place with the help of UDPG, that is uridine diphosphate glucuronyl transferase enzyme. This is present inside the endoplasmic reticulum. This conjugated bilirubin, now this conjugates the bilirubin, and now this conjugated bilirubin is the direct bilirubin. It is excreted in bile. It enters the GI tract. Sterile intestine contains glucuronidase enzyme as the baby has not started feeding properly. So it's a sterile gut. This enzyme degrades conjugated bilirubin to unconjugated form again, and this is reabsorbed from the gut, enters the blood and goes to the liver again for conjugation. This is called enterohepatic circulation. Once the baby starts feeding properly, there is colonization of the bacteria, normal bacterial flora, and then the activity of this glucuronidase enzyme will decrease and the enterohepatic circulation will not be there afterwards. Now, types of jaundice are physiological and pathological. Physiological jaundice, it may be a normal physiological or just an exaggerated physiological jaundice. While pathological jaundice, it will be conjugated, that is direct hyperbilirubinemia, and unconjugated, that is indirect hyperbilirubinemia. Physiological jaundice criteria: to say that it is a physiological jaundice, the direct bilirubin should be less than 2 milligram per deciliter. Appearance of the jaundice after 36 hours of age. Rate of rise of bilirubin less than 5 milligram per day, or usually, and it should not usually exceed any time more than 15 milligram per deciliter. Peak by 5th day and disappearance by 2 weeks. And the baby should be a healthy newborn. These are the criteria to say that yes, this jaundice is a physiological jaundice. Why there is physiological jaundice? Increased bilirubin synthesis is because of increased RBC load, and because RBCs are getting destroyed faster as compared to adults, and therefore there is more load of that, and there is enterohepatic circulation. Secondly, as I said, enterohepatic circulation. Thirdly, defective hepatic intake, because ligandin binding sites are less initially in the initial days of life. So there is defective hepatic uptake. Fourth, defective bilirubin conjugation, as in the initial days, there is decreased UDPG activity. And fifth, defective excretion because of meconium plugs, delayed feeds. This also can lead to increase in enterohepatic circulation and this will lead to physiological jaundice. Levels in exaggerated physiological jaundice, levels go slightly higher or may prolong for more than 2 weeks. Causes for slightly higher levels or prolongation of jaundice are polycythemia, delayed cord clamping, cephalhematoma, intraventricular hemorrhages, decreased calorie intake because of prematurity also it can be there, decreased conjugation due to decreased UDPG activity, and this can be seen in hypothyroidism, breast milk jaundice, or drugs. Certain drugs can decrease the UDPG activity and leading to exaggerated physiological jaundice. This can also occur because of decreased hepatic perfusion, because of hypoxia, congenital heart disease, and also enterohepatic circulation can lead to exaggerated physiological jaundice. Now coming to pathological jaundice for which we are worried for. It may be a direct or an indirect, that is conjugated or unconjugated pathological jaundice. At present, we'll discuss about the unconjugated hyperbilirubinemia pathological. This occurs mostly within 24 hours of life. Total bilirubin more than 15 milligram per deciliter. Direct bilirubin more than 2. Although indirect is more, but direct is going more than 2. Or rate of rise is more than 5 milligram per deciliter per day. Causes of indirect hyperbilirubinemia are increased bilirubin production, which may be due to bilirubin production. Why it will increase? If there is more RBC lysis. So it may be RH incompatibility, ABO incompatibility, hereditary spherocytosis, that is shape defects, enzyme defects, G6PD deficiency, pyruvate kinase, alpha thalassemia, or large doses of vitamin K themselves itself also can cause increase in the lysis of the RBC, leading to increased bilirubin production. It can also be hyperbilirubinemia indirect can also be seen in sepsis, pyloric stenosis, bowel obstruction. Due to decreased clearance, it can be because of inborn errors of metabolism, Crigler-Najjar syndrome type 1 and 2, or it may be autosomal recessive or autosomal dominant. And in Crigler-Najjar, it is seen that UDPG activity is affected. Decreased clearance may also can be due to hypothyroidism or breast milk jaundice. In RH and ABO incompatibility, why there is jaundice? During labor, fetal blood crosses to the some part of the fetal blood crosses to the mother's side. Antigen present on the fetal RBCs cause stimulation of antibody formation in the mother. Mother doesn't have any antibodies, she is negative. Antibodies are of IgG type. They cross the placenta and antibodies are formed in the mother. Now these antibodies are of IgG type, so they cross the placenta in enough amount in the next pregnancy. If the baby is again Rh positive in the next pregnancy, in the fetus they produce hemolysis, because leading to anemia and jaundice to the extent of hydrops fetalis. Mothers who are O group positive carrying AB fetus, this fetus can be isoimmunized by the same pathophysiology. Disease is milder in ABO incompatibility as compared to RH incompatibility. Investigations to be done in both of them are blood group of the mother and baby both, indirect Coombs test in the mother or direct Coombs test in the baby, serum bilirubin of the baby, complete blood count, peripheral smear to see for any shape defects, reticulocyte count, G6PD see for G6PD deficiency, etc. In Crigler-Najjar type, phenobarbital, as we see that in Crigler-Najjar there is deficiency of UDPG activity. Phenobarb is said to increase the UDPG activity, and therefore this is the drug of choice for that. In hypothyroidism, we have to treat hypothyroidism by giving thyroxine, and that itself will alleviate jaundice. Investigations to be done in these cases are the same, along with thyroid the thyroid profile, X-ray chest, abdomen, and all these are also included and blood culture, CRP. These are also included in the other investigations in a case of neonatal jaundice. Now, which is the high risk group which can get jaundice? It is prematurity, low birth weight, blood group incompatibility, birth asphyxia, infants of diabetic mothers, mothers receiving oxytocin, cephalomatomas, and problems in breastfeeding or any congenital malformations of the GI tract, along with sepsis. Now complications. Now once the baby gets jaundice, usually clinically we can see the jaundice by Kramer classification, that how the jaundice is progressing, or clinically we can judge how much is the bilirubin in this baby if the bilirubin is not easily being done. Now what are the complications of jaundice? Transient encephalopathy and kernicterus. Kernicterus, it is due to bilirubin toxicity of the brain. It causes staining, necrosis, and gliosis of the neurons. Parts affected by the staining are basal ganglia, hippocampal cortex, subthalamic nucleus, cerebellum, etc. Now, there are three phases of kernicterus. Poor sucking, lethargy, hypotonia stage 1, where we can again prevent, or the baby can come back to normal by treating this jaundice in different ways. Second stage is fever, may or may not be there, hypertonia, opisthotonous position. Third is high pitched cry, convulsions, coma, and then it can lead to death. The long-term complications of this kernicterus are chorioathetoid CP, mental retardation, and sensory neural deafness. Now, how we are going to treat jaundice to prevent these complications and other morbidities? Phototherapy is the mainstay of jaundice. Phenobarbital is the drug. Exchange transfusion, fluid supplementation, IVIG, metalloporphyrins, prebiotics, probiotics, clofibrate, rarely used. So these are the mainstay. Treatment of the cause, especially in hypothyroidism, sepsis, or congenital malformations, etc. Phototherapy mechanism, geometric isomerization, unconjugated bilirubin is converted to more soluble products like lumirubin. Structural isomerization, bilirubin is excreted in bile without conjugation. Bilirubin absorbs maximum light in blue range, that is between 420 to 500 nanometers. Blue and alternate white light use distance of 45 centimeters is maintained, and eyes and scrotum are covered. Indications for serum bilirubin means for phototherapy NOLA 12 more than 15 milligram per deciliter rising titers. Complications of phototherapy are hyperthermia, so hyperthermia, retinal damage, bronze baby syndrome, electric shock, loose tooth. These are the common complications of phototherapy. Exchange transfusion is the most rapid method of lowering serum bilirubin. It removes hemolyzed cells and antibody-coated RBCs. Amount of blood taken is 180 ml per kg, and RH of the mother and group of the baby is considered, but for practical purposes, O negative blood group should be selected to do exchange transfusion. It is done through umbilical vein canalization. Complications of exchange transfusion are sepsis, thrombocytopenia, portal vein thrombosis, umbilical vein perforation, arrhythmias, cardiac arrest, metabolic disturbances, HIV, hepatitis B transmission. Conjugated hyperbilirubinemia, these are the common causes, that is biliary atresia, neonatal hepatitis, torch infections, sepsis, hypothyroidism, choledochal cyst, and metabolic disorders. These are the common causes of high conjugated hyperbilirubinemia. But at present, we'll be dealing about indirect hyperbilirubinemia, which I've already told you. Thank you very much for listening to neonatal jaundice.